This is a 42-year-old lady who underwent YAG PI, both eyes, for angle closure glaucoma, and post YAG PI the vision had fallen down acutely and she was referred to our hospital. At our hospital we realized that she had exudative RDs in both the eyes, and a provisional diagnosis of VKH was made, and she was put on systemic steroids and immunosuppressants for more than 2 years, after which she did present with an immature cataract and posterior synechiae, for which Phaco was planned. And here initially I am making my 2.8 millimeter Phaco incision. I did keep pupillary expansion devices on hand. We did expect to use them, however, just see how the surgery goes. So here I am going ahead with my incisions. I then stain the capsule with trypan blue, as I usually do in such cases. Expel both the air bubble and the trypan blue with 2% HPMC. And then using a Sinski hook, I go ahead and separate out all the synechiae, the posterior synechiae. I also go to the mid part of the iris and separate those attachments as well. You have to not only separate the attachments at the pupillary margin, but also the further attachments of the iris to the anterior lens capsule. And once all those attachments are separated, I go ahead with my bent 26 gauge needle. This looks like an adequate pupil, and go ahead and fashion my capsular rhexis. Looks like I could get almost a 5 mm rhexis in this case. So I've sort of already decided not to use the expansion devices, and so far everything is going off well. The cataract is very soft, and that can be a problem, especially in us small people. I'm just pushing away the iris to see the rhexis margin. Go ahead, do my hydrodissection. I got a beautiful wave, and then I spin the nucleus around, breaking, sort of liberating the cortex, and I fill the anterior chamber. I put in some chondroitin sulfate. I now go ahead with my 2.8 millimeter Phaco tip, and I am going to use my Sinski hook as a chopper. And this nucleus, not only is it soft, it's very, the area that it occupies in that complex is so small that with a little bit of impalement you may wander off into the epinuclear area. It sometimes becomes very difficult to chop these nuclei. That doesn't stop me from trying, and you can see I'm already having difficulty here. So I just go ahead, keep rotating. I don't want to make a bowl here. And look what happens here. I'm trying to chop this piece, and the whole piece has got aspirated actually. So I rotate it and try to get another piece. And trying to do that, the same thing has happened. Just watch. I'm not able to hold on to it. It's just creating gaps within that nucleus, and sometimes this can be difficult. However, I have not given up, and there I've got a piece. Once you get one piece out, the rest is easy. However, you have to be a little careful. Just try to get the piece and bring it out and Phaco it. very easy to go through and through right to the posterior capsule. You have to be extremely careful. And this is more or less just the epinuclear shell that is left. I'm just trying to get hold of it. I'm only using vacuum here. And that's it. Once I get out that piece, the rest is pretty simple, although the pupil is not that large. I first remove all these nuclear bits and then go ahead and remove all the cortex as well. That bright reflex is due to the underlying pathology. There's a lot of atrophy in the posterior segment, and you get this bright red reflex. I do some posterior polishing as well with my polishing parameters. And then under HPMC, I inject my single piece foldable hydrophobic lens into the bag directly. Just checking with my Senski hook if the IOL has gone completely into the bag. It has. And then aspirate all the HPMC. I'm putting in some tricot, diluted tricot. I leave it for some time before washing it off. This is in the hope that it will control post-op inflammation. I finally wash off the chamber completely. And this is the post-op. You can see that PI there on retroillumination, and this is the first post-op day pictures. AC is extremely quiet, vision is 6/9, patient is happy. Thank you so much for watching.